breastfeeding. As you enter the room, we just have a few bits of information for you before we get started. I would like to draw your attention to the interpretation options for this event. This event is being interpreted in French, Arabic, Russian, and Ukrainian. Please choose your preferred language by clicking on the interpretation button. So thank you for celebrating World Breastfeeding Week with the Global Breastfeeding Collective. The Global Breastfeeding Collective is a partnership of prominent international agencies calling on donors, policymakers, philanthropists, and civil society to increase investment in breastfeeding worldwide. The collective's vision is of a world where all mothers have the financial, emotional, technical, and public support they need to start breastfeeding within an hour of a child's birth, to breastfeed exclusively for 6 months, and continue breastfeeding for 2 years or beyond. We are here today because the 10 steps to successful breastfeeding are evidence-based practices that improve breastfeeding rates by establishing benchmarks for quality care for new mothers and infants in maternity services. We are pleased to be here with you today to explore the 10 steps, learn about resources to advocate for and implement these baby-friendly practices, and get inspired by local experts. So today we'll hear about why the 10 steps are so important, why it's important to invest in these baby-friendly efforts, to get an overview of the 10 steps, and to learn from an expert panel. Immediately following this session, we will be handing over the mic to the Mommy Global Network and the Infant Feeding and Emergencies Core Group to learn 2 more ways you can step up to save lives, especially for those small and vulnerable babies. One more housekeeping item. If you would like to enable captions during today's webinar, you may do so by clicking the 3 dots and then selecting Turn on Live Captions. That will be in whatever language your computer is in. Please note that this feature is only available on the computer version of Zoom and not on your phone. If you have any questions today, please use the Q&A panel. And you can see it down there. If you are having any technical, If you are having any technical issues, please add a message to the chat. And I welcome you to use the chat to introduce yourself, where you are from, and your organization. My name is Elise Chapin. I work for the Italian National Committee for UNICEF, and I'm based in Florence, Italy. Okay, so as our first speaker this evening, this morning, this afternoon, our first speaker is Allison Tomilowicz. Oh, I see people are signing in. Thank you everyone for saying where you're from. Oh, excellent to see so many people from so many different parts of the world and so many different time zones. Thanks to all of you for signing in. All right. So our first speaker is Allison Tomilowicz, who is a senior program officer in the maternal, newborn, and child health team at the Bill and Melinda Gates Foundation, which she joined in 2019. Within the MNCH team, she focuses on maternal, infant, and young child nutrition investments aimed at answering questions of how implementation can be improved so that interventions can have greater impact at scale. Before joining the foundation, Allison spent 6 years with the Global Alliance for Improved Nutrition, GAIN, directing multinational teams to generate and translate evidence into programmatic and policy decisions. Prior to GAIN, Allison worked as a country manager and technical advisor with the Food and Nutrition Technical Assistance Project, FHI 360, in Guatemala, Mozambique, and Washington, D.C. She is a registered dietitian and holds a PhD in international nutrition from Cornell University and a master's in public health from the University of California at Berkeley. Over to you, Allison. I'm having trouble hearing Allison. I don't know if anyone else on the panel is. Yes, I can see people writing in saying they're having trouble hearing her. We'll see if we can get that back. Yes, thank you. In the meantime, thank you for all the people who are signing in from all different parts of the world. It's really wonderful to be able to celebrate World Breastfeeding Week this way. And fantastic to see so many people signed up and listening. I still can't hear Allison. Nina, should we move on to our next speaker or should we keep trying?
Thanks, Celeste. Let me just try one more thing, and we'll go from there.
Excellent, thank you. Okay, I see we still don't have any sound, but I do see that Francisco Branca has joined us, which is great. So why don't we start off with a greeting from Francisco. Francisco is the director of the Department of Nutrition for Health and Development in the World Health Organization in Geneva. If you haven't already seen his biographical information on the website, here are a few details. During his tenure, WHO has established a new nutrition development guideline development process and has developed a comprehensive implementation plan on maternal, infant, and young child nutrition with 6 global targets. He has also been leading the preparation of the 2nd International Conference on Nutrition. So I'll hand it over to you, Francisco.
Thank you very much. Good day, good colleagues and friends. Good morning to all. It gives me great pleasure to welcome you to the 2022 World Breastfeeding Week webinar series organized by the Global Breastfeeding Collective on behalf of UNICEF and WHO. First, let me thank you all for the extensive and continued efforts to promote, protect, and support breastfeeding. Breastfeeding is the single most effective public health action and the best start in life. It is a great equalizer and therefore a human right benefiting babies and mothers. The first few hours and days of life are a critical window for establishing breastfeeding. Over the last 4 decades, breastfeeding rates have improved, but much remains to be accomplished. Currently, 44% of infants are exclusively breastfed, while our collective ambition is to increase these rates to at least 50% by the year 2025 and 70% by the year 2030. The implementation of the 10 steps to successful breastfeeding have contributed to the progress and can certainly accelerate it further. The 10 steps to successful breastfeeding ensure maternity facilities offer all mothers and their babies clinical care that conforms to evidence-based standards. There is solid evidence that implementation of the 10 steps significantly improves breastfeeding practices and reduces morbidity and mortality in infants. The 10 steps need to be universally applied. They need to be the standard for quality care in all health facilities. Several new tools and resources have been developed by WHO and UNICEF, and others have been revised, updated, and expanded to guide integration of the 10 steps into national healthcare systems. WHO and UNICEF continue to support and sustain the baby-friendly hospital initiative globally. In 2018, WHO and UNICEF published a BFHI implementation guidance. This guidance focuses on achieving universal coverage and sustainability by mainstreaming the baby-friendly hospital initiative into health systems. It recommends establishing the 10 steps as the standard of care and emphasizes monitoring and data management systems for quality improvement. We will further support the implementation of the baby-friendly hospital initiative in healthcare systems by developing tools and resources for use in capacity building, adaptation, advocacy, and resource mobilization. Thank you for coming together today to discuss the implementation of the baby-friendly hospital initiative, reflect on experiences, and advance quality healthcare for mothers and babies everywhere. We hope the growing body of experience and the larger network of practitioners will help us move faster. Positive change in breastfeeding is not only possible, but is happening at scale. We must do all we can to ensure that every child's right to nutritious, safe, and affordable food and adequate nutrition is realized from the beginning of life, starting with breastfeeding. Thank you very much.
Thank you so much, Francesco. It's always really important to have the viewpoint of people like you who are responsible for enabling programs like the Baby Friendly Hospital Initiative to grow worldwide. We're going to try once more with Allison. So I'll hand it over to you, Nina, to get Allison going.
Thank you so much for the invitation to join you today. It's a pleasure to speak with you about the importance of investing in breastfeeding promotion, protection, and support. This year, World Breastfeeding Week is happening during an extraordinary time. The compounding impacts of the COVID-19 pandemic, conflict, and climate change have triggered a global food and nutrition security crisis with devastating consequences. In this global climate, investing in breastfeeding is more important than ever. We all know what's at stake, and we know the numbers. Scaling up optimal breastfeeding practices could save the lives of 800,000 children under the age of 5 and prevent nearly 100,000 deaths among women from diabetes, breast and ovarian cancer each year. And the economic benefits are just as extraordinary. Researchers estimate that suboptimal breastfeeding costs $340 billion each year in avoidable healthcare costs and lost earnings. And yet, there's been little increase in donor funding to support breastfeeding. In fact, recent analysis shows funding has actually plateaued. This is no time for donors to delay. This is the time to step up and commit to funding cost-effective, proven interventions like breastfeeding that will dramatically improve health outcomes for women and babies. Despite stagnant donor resources, many national governments have recognized the positive impact that increased breastfeeding can have in their countries. They are stepping up and leading, with real change happening at country level. We see governments promoting breastfeeding through regulations and changes to health systems, such as implementing the Baby-Friendly Hospital Initiative. We know that the BFHI has the potential to significantly increase success with breastfeeding. For example, one study found that adherence to 6 of the maternity care practices could reduce the odds of early termination of breastfeeding by 13 times. In Malawi, we've seen revitalization and scale-up of the BFHI in health facilities across the country, providing counseling on exclusive breastfeeding to more than 80,000 mothers prior to discharge. We've also seen increased attention to the International Code of Marketing of Breast Milk Substitutes. Between 2018 and 2020, 44 countries around the world strengthened their protections against inappropriate marketing of breast milk substitutes. This is a step in the right direction, though we need to continue to strengthen and enforce these policies to curb aggressive and misleading infant formula marketing. Country-level political leadership is now paying dividends, with an almost 7% increase in exclusive breastfeeding rates for children under 6 months of age over the last 8 years. But this is far below where we need to be in order to meet the 2030 global target, and it's going to take a lot more than political will to get us there. This community has long recognized that we all have a role to play in enabling optimal breastfeeding practices. It is not solely the responsibility of mothers. It takes many individuals at different levels throughout the health system, the community, the workplace, at home, to collectively create an environment that educates, encourages, and supports mothers. We need donors to do their part, to make investments in proven and context-specific interventions to help countries further scale up breastfeeding. At the Bill and Melinda Gates Foundation, breastfeeding has been a core component of our maternal, newborn, and child health and nutrition strategy from the beginning. And in partnership with many of you, we continue to support breastfeeding in several key ways. We're investing in infant kangaroo mother care, which involves skin-to-skin contact together with exclusive breastfeeding. A recent landmark study showed that immediately initiating KMC, rather than waiting until the baby is stabilized, increases the chance of survival by 25%. This simple shift could save 150,000 newborn lives each year. And for mothers of the most vulnerable newborns, we are investing in developing tailored breastfeeding support. We are supporting research in Bangladesh, Ethiopia, India, Malawi, Nigeria, Pakistan, Tanzania, and Uganda, exploring how to best deliver this kind of specialized lactation support. And we're continuing to expand and update the evidence base for breastfeeding. The forthcoming Lancet series on breastfeeding will cover the latest epidemiology and statistics and take a deeper look at the impact of breast milk substitute marketing on breastfeeding. The bottom line is we can and we must do more to meet this moment and to support mothers, starting in antenatal care and continuing throughout their breastfeeding journeys. We know progress is possible. And if we do our part, donors, policymakers, and civil society, to invest in breastfeeding to meet this moment, the impact could be transformational. Thank you again to the Global Breastfeeding Collective for your critical work, and I look forward to the rest of today's session.
Thank you, Allison, for sharing your insights in terms from the point of view of a donor and highlighting all the really important research that's been done that shows how important the 10 steps are as part of a quality of care initiative improvement that's enclosed in the Baby-Friendly Hospital Initiative. We'd now like to hear from some mothers. We're going to share a video that's entitled Voices of Mothers, and we'll hear about their experiences with the 10 steps and their breastfeeding journeys.
Night feeds are the hardest.
You're worrying about, is my baby getting fed enough?
When I gave birth, I had hypertension.
The first few days after birth, the baby was always hungry, crying.
It hurted so badly.
I was not very sure of the correct technique to breastfeed my child.
I come from a breastfeeding household.
I was determined to breastfeed.
La lactancia materna me ha permitido establecer una conexión con mi hijo, conocerlo mejor.
We created this beautiful bond together.
Breast milk is the best nutrition your child can get.
I received skin to skin as soon as my daughter was born, and support from the nurses and the lactation consultant.
She was on my chest for probably about 2 hours before the midwife actually then did all of her weighs and checks and things like that.
The head nurse helped me solve an issue where baby did not want to breastfeed on one side. Changing to a different position for feeding on that side solved the issue.
I was not very sure of the correct technique to breastfeed my child, so I struggled till the time the nurse came to my rescue. As the days went by, I became a pro.
Since my baby was a premature, I had to do like a kangaroo, so it was always kept on my chest as I was feeding him in between the kangaroo.
She also gave me supplies needed to clean my pump parts and syringes to help feed baby my pumped milk. I pumped to help the side that baby was not nursing from until we found a solution with a different position.
They supported and helped me with positions and how to recognize hungry signals.
My baby was with me the entire time I was in the hospital.
And then when we were home a couple hours later, I called the breastfeeding counsellor and she came over just to make sure everything was going well in terms of breastfeeding, and she was latching properly, which was really great.
And I'm really glad that I stuck with it and got the support and help that I needed.
I gave my baby exclusive breastfeed for 6 months, and I continued breastfeed up to 2 years. And I am very happy to say that my baby is very healthy.
I fed him for 2 years, so thanks for everyone who helped and supported me with my breastfeeding journey.
Los invito a practicar la lactancia y sobre todo a los empleadores privados y gubernamentales establecer políticas que ayuden a las mujeres a continuar con esta práctica para una mejor salud de ellas y de sus hijos.
Oh, it's always so moving to hear mothers talk about their experiences and really confirm what research may tell us, but it has a different meaning when a mother tells you how important the help she's received in reaching her breastfeeding goals has meant to her and her baby and her family. So I'd like to thank all the mothers who contributed to making this video from all the different places they managed to record their contributions to this video. So thank you for giving your time and sharing your stories. Our next speaker is Lawrence Grummer-Strawn, who is the unit head of the Food and Nutrition Actions in Health Systems Unit at the World Health Organization. He coordinates WHO work on infant and young child nutrition, treatment of acute malnutrition, and prevention of micronutrient deficiencies. He probably doesn't need much more of an introduction. However, he also, within WHO, leads the Baby Friendly Hospital Initiative, the Code of Marketing of Breast Milk Substitutes Group, and the Global Breastfeeding Collective. Over to you, Larry.
Good morning, good afternoon, good evening, everyone. I'm so happy to be with you on this BFHI promotion week. The messages that we just heard from the mothers is so critical. We really want to make sure that the experiences that they were getting with the support of breastfeeding becomes the reality for everyone. We need to make the 10 steps to successful breastfeeding a reality, not just for select mothers who go to special hospitals, but make this the reality for every newborn. And that's really what this webinar is all about. Next slide, please. So I think we want to start off by pointing out that we know these 10 steps work. There's quite a large body of literature. WHO reviewed this in 2017 when it updated the guidelines on the 10 steps. And I just put up one study here that points out mothers who tried to breastfeed, who started out breastfeeding, but didn't get the care of the 10 steps. 30% of them were not able to continue breastfeeding for 6 weeks. Compared to those who did get those right experiences in the first 24 hours, only 3% of them were not able to continue through 6 weeks. It's just one study that documents that this critical care in the first 24 hours is so necessary for making breastfeeding successful. Next slide, please. So we know it works. So how are we doing in terms of getting this around the globe? Unfortunately, far too many facilities have not been designated as baby friendly and aren't implementing the practices of the 10 steps. We did an estimate in 2017 and found that only 10% of births around the world are in baby-friendly facilities. And only a handful of countries in the world were able to reach a majority of births. Clearly, we've learned we needed a different approach to how do we actually make sure that these 10 steps get implemented for all babies. Next slide, please. So we put together a group to really look at how do we better implement the baby friendly. We created an external review group to really write this guidance and to work through all of the issues around the implementation of baby friendly. They looked at case studies from around the world, did key informant interviews in many countries, used a survey that WHO put out of what the experiences are with the implementation. We brought the world together in 2016 to celebrate the 25th anniversary of Baby Friendly, but also to have countries and regional groups coming together, talking in their own languages about how do we actually reinvent this initiative. We wrote up the guidance, put it out for public comment, had lots of discussion with the members of civil society organizations to finalize this guidance that we'll be talking about today. Next slide, please. So the new guidance came out in 2018, and it really focused, next slide, please. And it really focused on two main objectives. One of those was we needed to reach every mother and baby. It is time for us to be working toward universal coverage, not one hospital at a time, but how do we actually build those systems to make sure that the appropriate care defined in the 10 steps to successful breastfeeding becomes the responsibility of every facility. And secondly, that we needed to find a way to do that in a sustainable fashion. What we had found through that review was that over time, many hospitals had become baby-friendly, but then fell away. Many countries built baby-friendly programs to work through the technical assistance for hospitals, for training them, to designating facilities. But then that program fell away because of lack of interest, because of lack of funding. And so we really learned we needed to integrate the baby friendly as a standard of the healthcare system so that it doesn't depend on vertical programs, people being excited about doing it for a short period of time, but it actually becomes the standard for the health system. Next slide, please. So one of the things that we did here was to look at how do we actually build a national program that is actually going to support the 10 steps. Recognize there needed to be leadership and coordination at the center of all of this to really plan forward. How do we make these become the standard of care? We needed to write policies. We needed to write professional standards of care for pediatrics, for obstetrics and gynecology, for midwifery, for nursing, and make those the standards that are expected in every healthcare profession. We need to have healthcare professional competency building, which goes back to pre-service training, goes into making sure that we're really making sure that the competencies are there, not just providing courses, but actually assessing for the competencies and ensuring that our staff have that. We need to have external assessment systems. We need to have incentives and sanctions for facilities that are not adhering to these steps. And we need to provide technical assistance to facilities as they go through the quality improvement processes. Next slide, please. I want to go back to this external assessment and talk about it a little more in depth. When we talk about external assessment with the new baby friendly, we're really talking about ways to integrate the assessment into broader systems for quality assurance across the country. Those might be accreditation systems. They need to be streamlined so that they actually can be functional and sustainable. This doesn't necessarily mean that it has to lead to a baby-friendly designation. The focus is not on getting a plaque on the wall or being able to say this hospital is doing it right, this hospital isn't doing it right. It really needs to focus on how do we support all hospitals to provide the appropriate care that all babies need. Why have we moved away from a focus on designation that really was the focus of the baby friendly from 1991? One thing what we learned from this review was that the designation process was expensive for countries. It was expensive to operate as a country program, was also expensive for facilities as they went through trying to check every little piece of the application and prove that they could do all of the right things in baby friendly. And because it was so expensive, it was difficult to sustain. We also learned that it really wasn't a strong incentive for many facilities. That's why so many facilities never went through the process of trying to become baby friendly. That excitement of getting the plaque on the wall, the announcements that go in the newspapers and such, it's exciting for a time, but it's a short-lived thing and it doesn't last over time. It's dependent on advocacy and the publicity going into that that is not sustainable. And in many facilities, we found that it really depended on the competition. If there were multiple hospitals in an area that were vying for getting more babies to come there or to reach out into the population, then this might be an incentive for them. But in many places, they were the only hospital there. And so they didn't see that it was really important to have this designation. And the other thing that we've learned from the quality improvement literature is that internal monitoring tends to be more effective at sustaining practices than external monitoring that comes in from time to time, says what's going wrong, and writes a report about it. Next slide, please. Finally, there were just a few other things that we talked about, needing to have national monitoring systems to track that we are actually implementing these 10 steps across the board, that there needs to be better advocacy on an ongoing basis through legislation, through advocacy for legislation, advocacy for the Ministry of Health, making sure that we're always fighting for the rights of mothers and babies to get appropriate care. And finally, it needs to be financed in an ongoing sustainable way. That means with national budgets, not relying on donors coming in and implementing a vertical program to make baby friendly happen. But then when the donors walk away, the whole system walks away. Next slide, please. So some of the key points in the implementation guidance are that the standards of care have to be national standards, and all national standards must be based on the 10 steps. That we need to have the adoption of the 10 steps through a continuous quality improvement approach. That means using the science of quality improvement to make sure that we're really implementing within the hospitals the change processes and checking ourselves through monitoring systems on a regular basis. Are we actually implementing what we say we ought to be implementing? We need to shift from a project implementation approach to a systems approach, that we're actually making this part of the healthcare system and making sure all aspects of that system work to support the 10 steps. We need to make sure that our healthcare providers have the competencies to implement the 10 steps, because they don't just sit in a chair and have a course for maybe 20 hours as they did in the past, but actually we assess their competencies and make sure they are ready to go and have the skills that they need for implementation. We also emphasize in this implementation guidance that preterm and low birth weight newborns cannot be left out. They must be included as part of the application of the 10 steps because it is life-saving for them. Next slide, please. So I just want to close off with a few comments about the revisions to the 10 steps. We won't go through all of them. But each of these steps, some of the steps had some important changes in 2018. Step 1, we added that the code had to be considered part of the 10 steps. It had been there as part of the designation process, but wasn't part of the 10 steps. That we needed to have internal monitoring for continuous quality improvement as a regular process, and this needs to be built into the monitoring systems of each facility. In step 2, we shifted the focus from taking training courses into the assessment of competencies. In step 4, there had been some kind of back and forth. Initially, it was about early initiation, and then there was a shift toward thinking about skin-to-skin care. And the new 10 steps really emphasize that both are critically important. We need to have early skin-to-skin care, and we need to have early initiation in the first hour. Next slide, please. In step 5, go back one, please. In step 5, we need to have support to mothers isn't just about providing information to mothers about the right things for her to do, but really emphasizes much more that practical support and helping her through any difficulties that she might be having. It's much more of a counseling approach, hearing where she's at, what the issues are that she's facing, so that we're really addressing the issues that each mother has. Step 9 shifted the focus away from an absolute prohibition of pacifiers, but really emphasized more the counseling about their use and when they might be inappropriate, and if they do need to be used, how to do so in a safer way. And finally, step 10 that focused very much on what was happening out in the community. It was found was not really hospitals and clinics found that it was not their responsibility to say what was going on in the community. And so the focus really has shifted more to what their responsibilities are, to make sure they're referring to good care, and that they're allowing multiple options for how follow-up care can be done optimally. Next slide, please. So I just want to close off with just mentioning, skipped a slide, I think, go back one. Thank you. It's just to mention that there are a number of tools available on the WHO and UNICEF websites in terms of the verification toolkit for competency verification toolkit for how to assess that healthcare providers have the skills that they need. There's a manual about how to apply the 10 steps for small, sick, and preterm newborns. There's a curriculum for training. There's a training course for counselors in the community and in antenatal care. We have frequently asked questions about the code and how it applies specifically to healthcare workers. There's a model chapter about young child feeding that can be used for this pre-service training to make sure all healthcare providers get the skills that they need to support breastfeeding. Next slide. Just want to thank you for your attention. I hope you're as excited as I am about these new ways of implementing baby friendly so that all babies get the kinds of care that they need. Let's all take the 10 steps up that are absolutely necessary for all babies. Thank you all so much for your attention.
Thank you, Larry, for sharing that overview of the history of the BFHI. We'll now move into the portion where we have 3 panelists who are going to give a brief presentation, and then there's an opportunity to ask questions. Just as a reminder, please put your questions in the Q&A box and not the general chat. They tend to get a little bit lost in the general chat. So our first panelist, I'll introduce all 3 and then they'll each speak. So our first panelist is Elliot Deogracias, who is a nutritionist working at the Ministry of Health in the United Republic of Tanzania. She is an expert on child health and nutrition, maternal nutrition, programming and implementation of maternal and child nutrition interventions, and stakeholder engagements to inform policy processes and maximize national development. She is passionate about improving child nutrition in the health system. She has worked with different organizations and projects based on maternal and child nutrition, as well as in the planning and implementation of raising public awareness concerning child health and nutrition through different platforms. Our second panelist is Anne Woods, the Deputy Program Director of the UNICEF UK Baby Friendly Initiative. She is responsible for managing the assessment process for midwifery, neonatal, health visiting, and children's center services, and has worked with the UK team to progress the Baby Friendly program in the UK over many years, including implementing a staged approach to the external assessment process, introducing additional standards related to enhancing parental responsiveness and relationship building, and most recently, to enable services to fully embed and progress the work so that it is sustainable in the longer term. Anne also works as a lead assessor and facilitator of the various courses that Baby Friendly UK provides. With a background in midwifery spanning more than 30 years, Anne has a wealth of experience in all aspects of midwifery, including as an infant feeding coordinator and supervisor. Anne also holds the role of vice chair of the International Baby Friendly Hospital Initiative Network. Our final panelist is Yashwant Rao, who has an extensive experience as a pediatrician, healthcare management, and public health practitioner. Since April 2013, he has been heading the Department of Pediatrics in Ganesh Shankar Vidyarthi Memorial Medical College. in Kanpur. In 2021, he was appointed as proctor of the GSVM Medical College. He had earlier served there as vice principal. He has been a strong advocate for infant and young child feeding practices in the country and has facilitated multiple editions of breastfeeding and complementary feeding training courses for faculties, doctors, and staff nurses in medical colleges and health facilities in the state. He was one of the principal investigators for the Indian Council of Medical Research in the assessment of iodine status among pregnant women in India and an assessment of consumption pattern of food and food products high in fat, salt, and sugar among selected cities and towns and rural populations of India. He has led groundbreaking work during the COVID pandemic as a nodal officer for COVID training of medical and paramedical staff. He is currently responsible for a research project as the principal investigator for the Indian Council of Medical Research in optimizing the use of antibiotics for uncomplicated SAM management at community level. I need to remind the panelists, please, to stay within their 5-minute time frame, and I will pass the microphone over to Elliot.
Good morning, good afternoon, good evening. I'll be presenting on the implementation.
Elliot, you need to turn off the speaker in whichever second device is in your room.
Okay. Of the HFI in Tanzania. Okay, I'll be presenting on the implementation of the new direction of BFHI in Tanzania. I am Elliot the Greatest from the Ministry of Health, Tanzania, as a nutritionist working under the Ministry of Health. Tanzania is among of the countries that are committed to promote, protect, and support breastfeeding through implementation of baby-friendly hospital initiative since 1990. Please, can you go to the next slide, please? Okay, Tanzania is among all the countries that protect, promote, and support breastfeeding through baby-friendly hospital initiative since 1990. And it has been adopted as a standing program since 1992 through different approaches that have been used to the healthcare workers, including competence building, advocacy and sensitization, mentorship, so as to implement and support the initiative of baby-friendly hospitals for successful breastfeeding. In 2018, through WHO, the new guidance of protecting breastfeeding and supporting breastfeeding in facilities providing new changes in the 10 steps in successful breastfeeding and support its implementation, and the adoption, including the integration of the 10 steps into the health system approach, so as to improve in the support of a successful breastfeeding in the health facility. Next slide, please. Through the implementation of 10 steps includes the integration of 10 steps into routine services. Due to that, the 10 steps have been developed and translated to the local language that can be used by the healthcare workers, but also the development of implementation guide for 10 steps to support successful breastfeeding has been done in Tanzania, and the distribution of 10-step posters that have been in the local language have been distributed to the health facility to support and implement a routine communication to staff and parents and mothers who are breastfeeding, but also establishment of national standards care to protect and support breastfeeding habits in the health facility to mothers and caregivers and health workers. But also we have been integrating updated 10 steps to successful breastfeeding to the quality improvement guideline. This has been undertaken to the STAR rating tool, where you use the STAR rating tool to measure the effectiveness and the efficiency of the implementation of 10 steps in the health facility, how it is conducted, how it is done. It has been integrated so that to improve the quality of the services that are provided in the health facility based on the 10 steps that are based on the 10 steps for successful breastfeeding. Also, the development of national guidelines. This is also about the integration with other different health systems that are existing and the guidelines that are existing so as to incorporate the 10 steps and to make the efficiency or the implementation of 10 steps in the health facility and in the health system so as to improve the effectiveness and the efficiency of 10 steps in the health facility. But also Tanzania has strengthened the linkage between the health facility and the community, the linkage of 10 steps for successful breastfeeding from the health facility to the community. Tanzania, we have a community care groups, or we call community health workers, who have been capacitated on the 10 steps for successful breastfeeding and have been given the equipment, the knowledge, equipped with the knowledge on how to advise to counsel mothers about the exclusive breastfeeding, continuation of breastfeeding, and the initiation of breastfeeding within 1 hour. So community health workers, or we call community care groups across the country, have been capacitated and emphasize mothers who are pregnant during laboring or during birth. They should breastfeed their mothers within 1 hour. And the community leaders, the community healthcare workers, implement the knowledge or encourage mothers to go to the health facility during birth. So the implementation of 10 steps, it gives the linkage between mothers in the community and the healthcare workers, and the implementation become effective and successful. Thank you very much for listening to me, and thank you.
Thank you so much, Elliot. I'll hand the microphone now over to Anne Woods from UNICEF UK.
Hello, everyone. It's fantastic to see that the Global Breastfeeding Initiative is focusing on the 10 steps and BFHI, and it's a great honour to be asked to speak about our work in the UK. A little about the UK. There's a population of around 67 million with around 700,000 births per year. The UK has got a strong bottle feeding culture, a history of poor initiation and prevalence of breastfeeding, particularly the further north you go. So we made an early decision to adopt a UK accreditation rather than meet the global requirement of 75%. We're very fortunate to be part of UNICEF UK. It gives us a strong platform to advocate for baby-friendly initiative and breastfeeding, and has resulted in baby-friendly being recommended in many UK policy documents. It's worth mentioning the NHS long-term plan, which requires all maternity services in England to achieve accreditation by 2024, and similar strategy exists in Scotland and Northern Ireland. Services really value an award from an organisation with the credibility of UNICEF. Sorry, I should have said next slide there, Nina. Okay, next slide, lovely, thank you. As you can see, Baby Friendly in the UK has expanded across services, and 84% of maternity units have at some point achieved designation. A couple of key moments to flag. In 2012, we reviewed the 10 steps and the baby-friendly standards, and that led to including the importance of close and loving relationships in our programme, understanding how these impact infant development. In line with the current evidence base, including the 1001 days work, we included this as part of the standards, as well as more comprehensive standards for babies who are not breastfed. The 10 steps, including the code, remain, but are enhanced. And most recently, we had to look at how baby friendly can be made sustainable in the longer term, as so many services have been repeatedly redesignated. They told us it felt like they'd reached a glass ceiling. There was nowhere else to go. There were a number of factors which elevated these long-standing services and made it sustainable. Next, please. Firstly, leadership. Everyone in senior positions taking proportionate responsibility to make sure the programme works. Creating a culture of kindness where everybody believes it's their business. Staff and parents are encouraged and feel able to feed back about care and suggest ideas for improvement. Robust and ongoing internal monitoring, data collection at relevant time points, reporting on that data, and acting to improve outcomes. And lastly and crucially, progressing, evidencing improvements to service provision over and above what's required of the core standards. These 4 standards form an externally assessed accreditation for designated services, which leads to a gold award. Next, please. A couple of examples of the details. Creating the role of a baby-friendly guardian has been crucial. A high-level member of staff at board level who understands how baby-friendly fits into all local agendas and work streams and can advocate for the programme at a senior level. If you go into our website, you can hear guardians talking about their role, and this leadership standard has really been the biggest change, making baby-friendly everybody's business at all levels. Next, please. Creating that culture where it is everybody's responsibility and is a valued tool within the organisation to improve outcomes is supported by a survey of staff about their views. This is carried out as part of the Achieving Sustainability Standard assessment. At least 40% of staff are expected to complete the survey, which is engineered to discover barriers to change. Next slide, please. Knowing and understanding local data and developing the service to meet local need has improved outcomes and given permission to think big. As an example, you can see the increase in breastfeeding rates in this excellent service from when they were first designated, from 27% to 74%. Providing the additional layer of a gold award has enabled them to build on their achievements, gain credit for their innovation, and commit to embedding high quality care for the longer term. Currently, they're achieving 78% initiation and creating a culture where breastfeeding is seen as the norm. The Achieving Sustainability Standards offer somewhere to aim for, and they've really created a renewed enthusiasm and excitement about baby friendly in the UK. So to conclude, we believe that the whole package in the UK, external assessments for maternity, neonatal, community and university services, staging the assessments, the enhanced standards and achieving sustainability, underpinned by government support and within the UNICEF umbrella, has supported the programme to reach the point it is today. And there's lots more details on our website. Thank you very much for listening.
Thank you. And
that one wasn't meant to be there. That was meant to be hidden. I don't know what happened there. And that was meant to be hidden. Okay, sorry.
Well, that's what's always the fun part of being live on these events. Thank you for sharing that experience. We'll now go to our last panelist. Yashwant, are you? I'll hand the mic over to you.
Yeah. Hello, everyone. I'm audible?
Yes, we can hear you.
Yeah. Hello, everyone. Greeting from India, especially our state having poor data, Uttar Pradesh. It's good. Whole of the world is working on same platform on skillful implementation of breastfeeding hospital initiative at their own places. Initially, friends, I want to tell when I was a student, we were learning breastfeeding hospital initiative just to pass the exam, not to implement in the community, not for the beneficiary of the mother, not for the beneficiary of the babies, etc. And we were teaching few years before to our students just to pass the exam. But with the help of Alive and Thrive Foundation, we all three Department of OBGYN, Pediatrics and Community Medicine have lots of meeting to implement the skillful development of the breastfeeding hospital initiative. And policies, we developed the policy along with Alive and Thrive, promoting and protecting breastfeeding in India. We have hospital policy, make sure that all the mother and baby should receive the best care, strict adherence to infant milk substitute, feeding bottle, infant food, and it was in India, it was started in 1992, amended in year 2003. We have in our wards, in our OPD, in our IPD, written material for infant, young and child nutrition. Friends, for this, we did lots of training for the teachers, for the professors, for the junior residents, for the sisters, for the ward boy, not only for the ward boy, for the mothers and their family members, especially husband, mother-in-law, father-in-law, because they were the main hindrance in starting the breastfeeding soon after birth. So we teach the team of doctor, nurses by POCI approach on supporting and counseling the mother and families on maternal nutrition and breastfeeding during antenatal visit. Skin to skin contact and early initiation of breastfeeding, not within 1 hour, soon after birth, even soon after post-cesarean. During cesarean, we started breastfeeding to their babies. We established the exclusive breastfeeding here at our places. Antenatally, with the right support and counseling, most mothers adhere to the maternal nutrition and breastfeeding practices, and it was published in British Journal of BMJ this year in year 2022, and we provided the counseling on the mother diet, iron, folic acid, calcium supplementation, hemoglobin testing and treatment accordingly. We track and counsel the mother. Next, we track and counsel the mother regarding the breastfeeding, and we took the follow-up and do the counseling accordingly. We counsel and help prepare the mother for exclusive breastfeeding, and it ranges from approximately 0 to 75% with the help of Alive and Thrive, good counseling and interdepartmental coordination between pediatrics, community medicine and OBGYN. Next. Yeah. facilitating the skin-to-skin contact immediately after birth, and helping early initiation of breastfeeding in both normal and C-section deliveries, helping the mother to put their babies on the breast right way soon after birth, facilitating immediate and uninterrupted skin-to-skin contact, support the mother to initiate breastfeeding within 1 hour. We also supported the mother having cesarean section to do skin-to-skin contact and breastfeeding in operation room only. Please, and by POCT approach, it increased from 0 to 90% from January to May 22. Please show the video. During cesarean section, baby is taking mother breastfeeding. Please show the video. You can see. You can see mother is. You can see cesarean is going on and baby is taking breath. Next. Yeah. The MIOCN practices support with the breastfeeding. Breastfeeding is the natural and most mother need help at first at our place. Rooming involves a very important intervention. Staff nurse support mother with the correct positioning and attachment to the mother who actually require the support from the or help from the staff nurse. We support to manage the common difficulties during the breastfeeding. We support the mother to recognize and respond to infant cues like the voice of the baby when he developed hunger for the demand feeding, even in the antenatal, postnatal ward, NICU, and pediatric IPD. Rooming in very important part. Mother need to hear the babies their cues and respond immediately to give the breastfeeding. Ensure mother of sick baby can stay near their baby, and we develop here MNCU ward, mother and neonatal ward for sick baby. We started the policy of no supplementation. Do not provide breastfeeding newborn any food or fluid other than breast milk until unless it is medically indicated. We prioritize the expressed milk for the sick neonate who are admitted in our nursery. Next. Previous slide, yeah. Regarding the feeding bottle, teats and pacifiers, we strictly counsel the mother regarding not to use these practices and have the hygiene for their baby. Care at the discharge was very important because our failure rate was higher at the time after the discharge. When the mother goes to their home, they used to start other feed other than the breastfeeding. So we took care at the discharge, coordinate and counsel the parent during the discharge, and whenever they came to our OPD for immunization or for any minor problem or major problem, we used to take the history, how often you are giving the breastfeeding, and if there is any difficulty or any problem during the breastfeeding, we support the mother and we counsel the mother and their family member regarding breastfeeding. So these were the intervention, and we got a lot of changes at our place. Thank you.
Thank you for sharing your experience. It's been fascinating to see how applying the 10 steps of the Baby Friendly Hospital Initiative has been so transformative, both in Tanzania, in the UK, and in India. And thank you so much for sharing all of your experiences. We have some questions in the Q&A. Again, if you have a question,
yeah, please.
Please write it in the Q&A box, and we will be able to answer it. Some people have asked if the presentations will be available. Yes, the recordings will be put on the Global Breastfeeding Collective website in as soon as possible, and you can go review the presentations and the whole webinars, both this webinar and the webinar that's aimed for the Americas later on today. So I just had a couple of, let's see, we have a question from Irena in Croatia, who's asking, does anyone have any experience with competency training and assessment of maternity hospital physicians? Any tips to share? I don't know if our panelists have any or any of the speakers who have contributed since the beginning of the webinar. Does anyone have any experience they'd like to share about that?
I can share what we've done in the UK if that's helpful.
Sure.
We obviously, as in line with step
Excuse me,
2.
Anne, could you hold on for a second? We've just got a bit of a technical hitch, and some people on the main channel are only hearing Arabic. So just hold on for a second.
Okay.
Okay, let's try again.
Okay, just briefly, in the UK, in line with step 2, all staff are required to have training according to their role, and we provide some materials so that medical practitioners, both obstetricians and paediatricians, can be trained through the hospital, either face-to-face or through an e-learning programme. And then as part of the internal monitoring, we have a similar sort of competency tool to the new 2018 version. The infant feeding lead or the lead person in the hospital can interview the medical professionals about their knowledge base related to the standards.
Thanks, Anne. Is there anyone else who would like to take a minute to answer that question? Okay, if not, we can move on to the next one. It's a question for Elliot. Afia Bora Clinic has asked, how is Tanzania tracking exclusive breastfeeding and skin-to-skin indicators in the health system from the local levels of implementation? So, Elliot, I don't know if you're... There we go, thanks.
Hello.
Yes.
For Tanzania, IPF and skin-to-skin contact has been tracking in the health system because it's among all the indicators that are reported in the health information system. So we track it through the health information system. It's among all the indicators included in the health information. If it has been practiced, the skin to skin and the initiation of breastfeeding within one hover.
Okay, thank you. So if I understood correctly, it's being tracked through the health system, the information that gets automatically registered. So that's how they're able to do it. There is another question for Anne. What are current exclusive breastfeeding rates in the UK?
I'd love to be able to tell you, actually. Unfortunately, we had a very robust infant feeding survey that took place every 5 years, which gave us comparative data over a number of decades, and we haven't had that data since 2010. I'm pleased to be able to say that survey is in the process of being reinstigated, which is great for us because we'll be able to go back to having comparative data again. Individual services track their own data, so we've got, if you like, example data rather than broad spectrum data. And many of the baby-friendly services, such as the one I shared the example of, East Lancashire, has shown massive increases in their initiation rates. But we have very limited ongoing data, and it's very much service by service.
Okay, great, thank you. We have a question, a couple of questions about pacifier use. So the new step 9. The approval of pacifier use in the new guidelines has resulted in a marked rise in bottle use for hospital supplementation instead of cups. Have any of the panelists noticed this? And if so, what is your approach to that? Can pacifiers not be prohibited and encouraged instead? So lots of questions about pacifier use. I'm not sure how that gets addressed in any of the countries who spoke, so Tanzania or India or the UK. Okay. I know we're having some technical difficulties, so it may be hard for some of our panelists to answer. And I don't want to tax you over much, but I don't know if you have a quick answer for that.
I mean, I suppose our quick answer would be that it hasn't really changed within the UK. We've maintained the sort of way we've always approached pacifiers, which is through an informed conversation and a decision made based on mothers having the information about the negative impacts or the impacts of pacifiers. We have seen some increases in supplementation recently, and I think it's probably more COVID driven. Mothers wanting to get out of hospital more quickly, perhaps, and feeling that their route to a quick exit is to perhaps give their baby some formula milk. But I wouldn't have said it's related to the change in the steps. I think it's more related to the difficult circumstances we've all been through.
Yeah, that the entire global health system has been under such strain in these last couple of years. Someone asked about the UK's NICU baby friendly initiative. I would send you to the UNICEF UK website, which has lots of information about that, so that we could look at another question that's come up about how adopting the 10 steps, the question is, what influence has it had on primary healthcare settings? Has it improved care for your community? And that's a question for all of the panelists. How has adopting the 10 steps, the baby friendly, changed care in your community? I think Anne mentioned in her talk about building responsive parenting, responsive relationships, really focusing on that. Was there anything that Elliot or Yashwant would like to underline about how the baby friendly has changed care in their community?
Yes, actually, with the implementation of the skillful implementation of the baby friendly hospital initiative, mothers are very happy, their family member are very happy, and initially only mother is being counseled. Now all the family members, with the counseling of all the family members, whole of the family is gathered for their baby to give the breastfeed within 1 hour after birth, and this enforces focus group discussion and group discussion. The whole of the village and whole of the areas are being promoted towards having breastfeeding. And during counseling, we used to use the word it will increase the IQ of your baby more than if your baby takes the powdered milk or any substitute of the milk. So families are more rendered towards starting the breastfeeding, and this makes this program very successful. And if the mother and baby is taking mother feeding and proper counseling, then baby will be healthy and whole of the community will be healthy.
Okay, great. Thank you, Yashwant. Elliot, do you have anything you want to add about how it has changed care in your community?
Okay, baby friendly has changed the perspective of mothers in the community. When they initiate breastfeeding at their health facility and skin-to-skin contact, it creates a bond between the mother and the baby and the parents or the relatives around, and they support the mother to breastfeed. but also it has bring more impact for mothers to be anxious in breastfeeding. They excited for breastfeeding their baby exclusively. That's one of the advantages you have seen in the community. Thank you.
Great, thank you. I think that message of the reaction of mothers came through in the video that we saw earlier as well. So some of the challenges that you experienced in implementing the 10 steps as part of the baby friendly, what type of challenges did you experience, and how did you overcome them? All of you, any of you?
Shall I maybe start again? I think we were starting from a very low base when we started in the UK. We did have this very, very strong bottle feeding culture, which was across both, mothers and staff. So the knowledge base of staff needed improving, and the baby friendly and the 10 steps really enabled that to happen. I think advertising has been a huge challenge and still is a huge challenge, as was highlighted earlier in the year. And I think probably sort of a lack of belief almost at the beginning that the 10 steps would make a difference. But actually, once services started to implement the 10 steps and the standards and saw the difference it did make, and there started to be a growth in evidence around the impact of baby friendly, we started to see that buy-in from the government and the inclusion of baby friendly in the various policy documents. And then that really helped to build that momentum and that interest. And I think the other thing that we did to help keep that interest was to keep it fresh. So, having different standards for different services. You talked about the community having a set of standards we have like health visiting, public health nurses, so a set of standards for them to implement to keep breastfeeding going, because there was sort of no point in getting higher initiation rates if we weren't able to support mothers to keep going with breastfeeding. So different standards in different services, breaking it down so that doing it in stages, which I know a lot of other countries have done. So you can achieve different stages at different time points, and it helps build and work towards final accreditation. And then these newer standards, which are talked about around the relationship building and responsiveness, which really did feed into the narrative at the time and the interest that was building in early newborn development and baby brain development, the 1001 days, all of those sorts of things. So it's been that ongoing building, and the achieving sustainability standards, this idea that you can get another level of award and bring everybody in the hospital into play in supporting that hospital initiative has really captured people's imaginations and really helped us to keep that interest and enthusiasm building.
Great, thank you so much. Yeah, Yashwant, yes, please.
Yeah, actually at my places, most important hurdles were the doctors and staff, because our hospital is bed occupancy is more than 150%. So doctors were more keen to have the medical work than doing the counseling, implementing the policy of breastfeeding initiative. But with the help of Alive and Thrive, when all the three department of community medicine, OBG, gynae and pediatrics came on the same platform, then we thought that if we implement this policy, there will be a lot of changes in the newborn survival, lot of changes in the mother survival. And the initial hurdles were the doctors and paramedical staff. When we were trained and we were counseled ourselves, then it became the successful, and we are doing it successfully at our place.
Thank you. Elliot, any challenges and solutions?
Okay, for Tanzania, among the challenges that we incurred during the implementation of baby-friendly hospital initiative, it's about data quality management, as when you implement something, you need to see the effectiveness and the implementation of it and see the outcome. But on the term of data quality was still a challenge, but we came out to realize and mitigate the challenge by integrating these indicators into the other health information indicators. Like I have said in my presentation, we integrated the indicators into other maternal newborn child indicators and other quality improvements indicators so that we can mitigate and see the effectiveness of this implementation of 10 steps. But also we came to realize having adequate resources and integration and solid strategies for following up and mentorship to healthcare providers, to all healthy team who are supporting mothers to initiate 1 hour breastfeeding skin to skin contact is very vital for having a BFHI successful in the health system. Thank you.
Thank you. I think mentoring is so important, and that sort of emerged in all of your presentations, the building momentum for implementation of the 10 steps in the BFHI. There is, so some people have asked about implementing step 10 in the UK, in Tanzania and India. The webinar that's following this will actually be addressing step 10 more for small and vulnerable newborns. But do you have, any of you panelists have anything you'd like to say specifically about step 10, about ensuring that there's continuity of care?
I think within the UK, because we're very lucky, I guess, that we have the public health nursing system. So there is that ongoing system of support for families after they've left the hospital, initially by community-based midwives and then going to the health visitors, the public health nurses. But part of the standards require that there is more like peer support or support within groups. So the ability to talk, to have that social support, talk to other mothers who are breastfeeding, you know, so that you can have that almost mentorship from other mothers. The other thing that we've implemented is a requirement for a sort of specialist level service, so that those mothers with particular challenges when they leave hospital that crop up later on will be able to access somebody with a higher level of knowledge and support who can give that additional layer.
Great, thank you. Any help that you can give from experience in Tanzania or in India about implementing step 10?
Okay, for Tanzania, for continuity of care, when a mother leaves the hospital, we have what we call community health workers who are living nearby the mothers from the hospital. They visit and continue providing counseling, education, and helping them about baby positioning, exclusive breastfeeding, what mother should eat for her having more breast milk, and contact workers and health facilities. So they integrate and help mothers to continue breastfeeding and have a when a mother got something like a problem or a certain, bring the mother to the health facility for getting a service. Thank you.
Thank you. Yashwant, do you have any insights for step 10 that you'd like to share? Okay, perhaps not. My last question was about what lessons can people take away from your experience? And Anne, I'm not going to ask you to answer that question because I'm actually going to read a comment that's in the Q&A that says, I work at an NHS hospital who has just achieved their BFI level 3 accreditation. Personally, I feel applying the 10 steps enabled us to really put lactation education into priority and to help staff have clear policy and procedures to follow to enable all mothers and babies to have the best possible start. I think that's a great lesson. I don't know if you have anything you'd like to add. Elliot, is there something, a lesson that you'd like to share with everyone at the webinar today?
The one you mentioned is very clear, but maybe we can say baby friendly hospital initiative, coordination, that's what we learned. Coordination, it is multi-sector approach. We need a multi-sector approach to coordinate BFHI to have a successful breastfeeding and have all babies who are born to be breastfed and exclusively breastfed. It is very important for successful BFHI. Thank you.
Thank you. And Yashwant, any lessons that you would like to share with the webinar participants today or those who are listening to the recordings? Just while Yashwant, maybe we get the technical things ironed out. Yes, Lisette, this will be available as a recording. So don't worry. Yes, very exciting that the new model chapter will be coming out soon. And any other questions that have popped up, I apologize. I cannot read the question in Russian. Let's see. Oh, Yashwant, well, there's another question about India, about skin to skin. Maybe thanks to that video you showed in your talk, and about the difficulties of initiating skin to skin. I don't know if there are any other lessons that you'd like to highlight. I think it's been fascinating to hear about what you've been able to do in each of your countries with very different systems, and yet the same type of passion and the same attention to detail to ensure that families do have the experience that they're looking for. We do have, and Nina, I don't know if you can give me put up the last slide with our call to action, because this wouldn't be World Breastfeeding Week activity if we didn't have a call to action. You can see on the screen a QR code. If you take a picture of that QR code, it will take you to sign the declaration about end exploitative marketing. So everyone who's on the call today and those who are listening to the recording are encouraged to sign that. Anyone who's been following the publications that have come out in these past few months about exploitative marketing may have already done that, but if you haven't, there's still time to do that. What we're looking for, if you are a part of an NGO, civil society, a trade union, academia, professional bodies, communications, technology, early childhood development, health, or the nutrition-related sector. Our question is, are you a part of an organization that advocates for breastfeeding in your country or region? You could consider becoming an associate of the Global Breastfeeding Collective. You can visit the link, as I said, on the screen, or click on the QR code, click on the link, or photograph the QR code. So we hope you've enjoyed this first part of the webinar. I'd like to thank the people who spoke today. Francisco Branca from WHO, the members of the task force, the Global Breastfeeding Collective Task Force, which is coordinated by UNICEF and WHO, the mothers who contributed to the video, Allison and Larry who spoke, our panelists who all spoke. Thank you all for sharing your experiences with us. And as this part of our presentation comes to a close, I hope you'll stay in the next segment and learn about 2 key ways you can step up to save lives. So Nikki Connell from the Emergency Nutrition Network will be representing the MAMI Global Network on enhanced lactation support for small and nutritionally at-risk infants in the first 6 months. And then Jodine Chase from the IFE core group will talk about what's next for infant and young child feeding in emergencies. So I will hand it over to you, Jodine, and thank you again to all of you who are listening today, who are listening to the recordings, and all of our speakers who so generously shared their time and expertise.
Thank you so much, Elise, and thank you so much to the Global Breastfeeding Collective for hosting us. I will share my screen now and move into our part of the presentation. So welcome to 2 more reasons to step up. I'm Jodine Chase, the Infant Feeding and Emergencies Core Group Facilitator. First, we have a presentation from the MAMI Global Network, represented today by the Emergency Nutrition Network's Nikki Connell. And then after, I'll be coming back to present a new report being launched today. So please post your questions in the Q&A as you think of them. We have a couple of volunteers today who will answer some of the questions directly, and some will be answered by me and Nikki during a short Q&A at the end of our presentation. Go ahead, Nikki.
Thanks, Jane. Hello, everyone. My name is Nikki Connell, and I'm a Senior Technical Associate with the Emergency Nutrition Network. We're delighted to join your webinar today and see how we can join forces to enhance breastfeeding support and continuity of care for small and nutritionally at-risk infants under 6 months of age and their mothers, what we refer to as MAMI. We will introduce the MAMI Care Pathway Package and how it can help put step 10 of the 10 steps to successful breastfeeding into practice. As a reminder, step 10 is coordinate discharge so that parents and their infants have timely access to ongoing support and care. Next slide, please. So what is the problem we are facing? MAMI refers to the management of small and nutritionally at-risk infants under 6 months and their mothers. Small and nutritionally at risk includes infants that are born too early or too small, babies that may be born wasted, underweight or stunted, and those that become malnourished or falter in growth after birth. Millions of infants are affected in the world, as shown by the figures on the slide, and this is a problem across both humanitarian and development settings. Overall, globally, 1 in 5 infants under 6 months is small or nutritionally at risk. These infants are at higher risk of illness, death, poor development, and long-term ill health than their healthy counterparts. For example, an infant with severe underweight in the first 6 months of life is nearly 5 times more likely to die than a healthy infant. Next slide, please. Nutrition for Growth commitments, which outline country commitments to tackling malnutrition in all its forms, have recognised the need to target services to small and nutritionally at-risk infants and their mothers if the required progress is to be made. For example, Ireland has committed to take a leadership role on the issue of wasting globally, and in particular, programming targeted at small and nutritionally at-risk infants. So the political leadership is there to address this issue, but we all need to support progress in practice. Next slide, please. Step 10 of the 10 steps to successful breastfeeding translates to coordinating discharge so that parents and their infants have timely access to ongoing support and care. At present, we see a gap in practice for vulnerable infants and mothers, particularly from when an infant is aged 6 weeks to 6 months. We see poor continuity of care for at-risk infants beyond the immediate postnatal period. Proactive screening for problems is not common. For mothers and infants that do present to health services with clinical or feeding problems, specialised support for breastfeeding up to 6 months of age is often lacking. And we have an over-reliance on inpatient care, with community-based outpatient services rarely available. Breastfeeding is critical to the survival, growth and development of children worldwide. It is especially so for those young infants who are the furthest left behind. We're here today to see how we can work together to close the care gap and improve access to breastfeeding support for these infants using the Mammy Care Pathway package. Next slide, please. The Mammy Care Pathway package is a piece of implementation guidance that comprises a care pathway framework, user guides, and health worker support materials, including forms, counselling cards, and a support actions booklet, to assist practitioners to identify, assess, and manage small and nutritionally at-risk infants under 6 months of age. The Mammy Care Pathway package applies an integrated care pathway approach with a view to achieve continuity of respectful quality care for infants and their mothers across health and nutrition services. It was developed by the Mammy Global Network, led by the Emergency Nutrition Network and the London School of Hygiene and Tropical Medicine, to help put WHO recommendations for community-based care into practice. Next slide, please. Skilled breastfeeding support is central to the Mammy Care Pathway as part of a broader package of clinical care and social support. Mammy covers both maternal and infant health and nutrition, as well as referring pairs on to relevant social and child development services available. Next slide. Mammy links prevention and treatment, but how does Mammy fit in with the breastfeeding services you are already providing through IYCF programming? Mammy dovetails with IYCF interventions that operate more at the primary prevention level. Mammy focuses on secondary prevention, early detection of problems with timely intervention to prevent further deterioration, and also tertiary prevention, which is urgent action to prevent serious consequences of problems should primary and secondary prevention fail. IYCF and Mammy are both essential and complementary initiatives for infants and their mothers. Next slide, please. Now, this is a busy slide, so don't worry about reading every detail. The Mammy Care Pathway applies, builds on, and connects existing nutrition and health services across primary, secondary, and tertiary care. Care is focused at the community level where there is the greatest gap. Screening can happen from pregnancy right through to when the infant is 6 months of age at a range of health contact points. For example, the infant's first vaccination at 6 weeks, and moderate risk infants and their mothers who are identified and enrolled in community-based care receive individualised support and counselling for specific feeding and clinical problems. Those that are at high risk are referred to inpatient care until they are considered moderate and can be referred into outpatient care. All infants are enrolled for support to 6 months of age. Next slide, please. So how is the breastfeeding support provided to these infant mother pairs different and complementary to what might be provided in community breastfeeding support programs? First, this is a package of care that targets skilled breastfeeding support to at-risk infants under 6 months and their mothers, rather than to the general population of infants. The needs of these infants may be more complex and the implications of not getting it right even greater. Secondly, skilled breastfeeding counselling is embedded in a larger package of clinical and social care. This may involve referrals to clinical services, maternal mental health services, and other context-specific support that the pair may benefit from. Thirdly, infants and mothers receive specific, regular and continuous support up to 6 months of age and are not discharged from services until that age is reached. And lastly, as the mother-infant pair are being seen regularly, at-risk infants and mothers remain on the radar of the health service, so they are primed for early intervention and referral for specialist care if required. Here is an example of how step 10 might look in practice. In Rwanda, a successful focus on supporting preterm and low birth weight survival provided a new challenge. 1 to 3 years post-discharge from a neonatal intensive care unit, infants were found to have higher rates of feeding difficulties, as well as anemia, underweight, wasting, and stunting. The services required to address the nutritional challenges were not available in the community. The Ministry of Health, UNICEF, and Partners in Health collaborated to set up 8 clinics to provide focused medical and nutritional follow-up post-discharge. The nutritional component involved training nurses to provide comprehensive feeding counselling and support. This was based on the Mammy Care Pathway package. A simple algorithm was developed to guide nurses on how to identify, assess, and support feeding challenges alongside other medical support. By moving this support out of the hospital and into the community, it could be provided on a regular basis with follow-up. You can read more in ENN's publication field exchange at the link provided on the chat and the slide. Next slide. So now we know that putting step 10 into practice is critical to realising continuity of care between health and nutrition services for at-risk infants and their mothers. Early identification of at-risk infants under 6 months is an essential action to prevent further decline in the nutrition status of an infant, and the Mammy Care Pathway can support this. It is also clear that skilled breastfeeding counselling is a core component of care for small and nutritionally at-risk infants, a service that needs strengthening in community-based outpatient care. We have a common goal to achieve coordinated discharge so that at-risk infants under 6 months and their mothers have timely access to ongoing support and care. We call on you to join the Mammy Global Network's efforts to work together to reach the most vulnerable and at-risk mothers and their infants. Thank you for listening.
Thank you, Nikki. Let me just adjust the slide here. Hi again, I'm Jodine Chase, the IFE Core Group Facilitator. We've been called to step up for breastfeeding in this webinar, and we have learned so much already. This last section is about how we are called to step up during emergencies. We all know these numbers. Almost 90 million people forcibly displaced by the end of last year, and the rate of displacement due to climate change is twice the rate due to conflict. Children are 30% of the world's population, but they make up 41% of those displaced. Suboptimal breastfeeding leads to an excess of 820,000 deaths per year, while exclusive and continued breastfeeding alongside complementary feeding is the single most effective intervention to prevent deaths in children under the age of 5. So when protection actions like the 10 steps are in place, and when Mammy Care is available to support the most vulnerable infants, communities are more likely to be breastfeeding communities, and these are better prepared for emergencies. Disasters and humanitarian emergencies disrupt breastfeeding, and additional support is needed both to preserve breastfeeding and also for the food insecure, including those partially or fully dependent on infant formula. We heard earlier this year from WHO how the pervasive, misleading, and aggressive marketing from the $55 billion formula milk industry causes harm. This is especially true during emergencies, which are often exploited through floods of donations and uncontrolled distribution of breast milk substitutes and infant foods. This undermines appropriate infant and young child feeding practices, both during the emergency and beyond. So about 20 years ago, the IFE Core Group was born. It's a global collaboration of agencies and individuals, and it developed operational guidance with evidence-based actions to safeguard life-saving infant and young child feeding in emergencies. In 2010, the World Health Assembly urged member states to adopt the guidance into their own preparedness plans and emergency responses. Now, 10 years since this call to countries for action, we're releasing the first ever report to examine the progress of member states in fulfilling this commitment. The report has found that progress is being made at the policy level. And at the same time, coordination, capacity, and clear systems for tracking progress are lagging. There are gaps in functional multi-sectoral systems to support recommended infant and young child feeding practices in emergencies. This report aims to galvanize member states and the humanitarian and development community to deliver on the global IYCFE commitment. Countries are taking measures. An increased proportion of countries in NutriDash report working on programs to support appropriate IYCFE, from 62% in 2016 to 78% in 2020. Kuwait and Lebanon implemented all elements in 2016. Nigeria developed a plan in 2018 that links emergency activities to existing policies and nutrition plans. The global trend in government funding beyond staff salaries has increased over time, but it remains well below the number of countries that report work or the presence of policies, strategies, or action plans. Until 2019, no region had more than 40% of its countries reporting funding beyond staff salaries. Available data suggests significant gaps in the availability of activities that support caregivers in nourishing their infants and young children in emergencies. These gaps exist despite the evidence that these behaviors and the services supporting them are life-saving. Current global data is inadequate to assess the numbers of people needing action, to track unmet needs, and to assess the impact of the emergency and beyond. There's no formal mechanism for member states to measure their progress, and there's no requirement to do so. And there's no consensus around methodologies for analyzing data in global databases to distinguish between emergency and non-emergency contexts. Member states have primary responsibility to provide leadership, policy, funding, monitoring, and coordination for preparedness and response to emergencies. And progress has been made, and there are many gaps. Governments must take the lead, and this report offers 6 recommendations for member states. A systems approach is needed, and 6 recommendations are also offered for humanitarian and development communities, recognizing the important and synergistic contributions they make towards creating environments where caregivers can consistently nourish their infants and young children. The first recommendation for governments is to step up and ensure that national and international preparedness plans and emergency responses include adequately funded actions as outlined in the operational guidance. And the humanitarian and development community is also being asked to step up and to develop and deliver on a policy advocacy agenda to promote uptake of actions outlined in the operations guidance. In the words of Victor Aguayo, Director, Nutrition and Child Development, UNICEF, and Francesco Branca, who we heard from earlier, from the WHO, the COVID-19 pandemic has made it clear that all countries are at risk of an emergency. Now is the time to consolidate gains from the global emergencies of the past decade and to channel these gains into our routine systems and into our preparedness and response capacities. How can you step up? Please start by downloading the report, which will be shared widely in coming days. You can use it as a tool to start a conversation in your country and to hold those responsible to account. So thank you for listening to our presentations. We now have some time left for questions and answers. So note also that all the questions and answers will be shared in a document on our website in coming days after the webinar, even if your questions aren't answered right now. So Nikki, here's a question that applies to both of us. Can these resources and guidance be used in any country or any setting? Or are they specific to developing countries or to emergency settings? I'll answer for IYCFB, and the answer is yes. One good example is how Ireland will use the operational guidance to develop their own plan in a non-development setting within Ireland. Thinking about the operations guidance more broadly, it's been used in many countries, including my own country of Canada, and it's certainly relevant to strengthen support for optimal infant feeding. What about for Mammy, Nikki?
Thanks, Jodine, and the answer is the same. Yes, of course, it's appropriate for use in many settings where there are vulnerable infants, which includes both development and emergency settings. We know that support for skilled breastfeeding falls way short in Ireland and the UK, for example, including in health facilities, as we heard earlier. The reasons why infants may be at risk in these settings could include premature infants and infants with a disability. So like anywhere, the materials are designed for adaptation and contextualization, so could apply potentially to any setting. I think you're back on mute, Jodine.
I am back on mute, thank you. Another question for you, Nikki. If I want to get involved in Mammy and support these vulnerable infants and mothers in my context, what would the first thing that I need to do be?
Of course, we're hopeful that many people will get involved in the Mammy Care Pathway package and the Mammy work in general. I would say the first thing to do would be to download the Mammy Care Pathway package available on the Emergency Nutrition Network website. We have been sharing links to that in the chat box. And then review those resources and gather relevant stakeholders across both health and nutrition to discuss what the needs are, what the current situation is in your context, where the gaps are in service provision, and how the Mammy Care Pathway could work in your context. It may not be possible to provide or access all services outlined in the Mammy Care Pathway immediately, depending on what other services are available across different sectors. But don't let that stop you getting started. You can start off with what is available and build up as you go. Plus, joining the Mammy Global Network, which is free for all to join, and connecting with other service providers in other contexts will facilitate learning from each other and give you tips and expertise to apply the Mammy Care Pathway package to your context. And details on how to join can be found on our website as well. And I believe there's a link in the chat to help you get directed to the right place.
All right, and so we have a little bit more time. This next question is asking about the evidence base showing that the Mammy Care Pathway actually works.
Yes, there's been a lot of work building up the evidence towards the Mammy Care Pathway and how it might work in practice. And that's both has happened already and is ongoing currently as we speak. Core contents of the Mammy Care Pathway package are based on and are intended to help operationalize the World Health Organization guidelines for the management of infants under 6 months with severe acute malnutrition, published in 2013. The WHO guidelines are currently under extensive revision and are specifically looking at prevention and treatment of growth faltering in infants under 6 months. Recommendations are due out end of this year or early next, hopefully. The package builds on a broad range and a variety of accumulated evidence and experience and applies well-evidenced interventions like the integrated management of childhood illnesses and breastfeeding counselling to the context of at-risk infants and mothers. Significant research is underway or planned to build a direct evidence base, including a randomized controlled trial in Ethiopia, state-level research in India, and an intervention trial in South Sudan. Suggested interventions are fundamentally behavioural in nature and low risk, but with a high potential for benefits if implemented well.
And Nikki, can IYCF counsellors deliver aspects of Mammy services?
Yes, definitely. Skilled IYCF counsellors are well placed to provide this type of support. As we saw in one of the slides, skilled breastfeeding counselling is central to the Mammy Care Pathway package, and we rely on skilled counselling support to provide that service. The feeding situation of the most vulnerable infants may be particularly challenging, and counsellors should be experienced and may require some additional training as well in order to deal with their specific issues. We need to make sure that they have the resources and the time they need to deliver high quality services, which is where the Mammy Care Pathway package can assist and support. But I'm sure many of us on the call here today have had experience of implementing support for infants and struggling with those that are not doing so well, that are more vulnerable. And so the Mammy Care Pathway aims to go some way to addressing that gap and being able to guide practitioners on how to deliver the more specialised skilled support for those most in need.
Yes, we have a few more Mammy questions. The next one is, are there guidelines on cultural competence available for healthcare workers to provide better breastfeeding support for migrant women?
The Mammy Care Pathway outlines specific resources that are available to support those most in need. My belief is that there are not specific guidelines for migrant women, but they are a cadre of women who require specialised support. So in the same way as any other mother who requires specialised support, the pathway can be adapted to support them. So, for example, there has been some work done in contexts where migrants have been part of that. There have been refugees or folks on the move, and the pathway can be adapted to support them. Of course, it's the same as any other programme, and IOICF services more generally as well. There are specific challenges that migrant women face, and the care pathway package would need to be adapted to facilitate support optimally to those women. But yes, it can be provided adaptation.
And certainly from an infant and young child feeding and emergencies perspective, the supports needed for migrant women and their infants are significant, and a big piece of the on the ground work that is done implementing the operations guidance addresses specifically the issues that these families face while they are in transit. I know there have been some transit guidelines developed in recent years that are specific to supporting both those who need to protect their breastfeeding and also those who are reliant on infant formula. Next question, I apologize, my screen went blank while I was answering. What are the next steps to scale up Mammy worldwide? The comment is, for sure, WHO and UNICEF inclusion of new updates in nutrition guidelines, but what about at country levels?
Yes, an excellent question. And this is really the work of the Mammy Global Network. So I encourage you to visit the website on ENN's website, the webpage on ENN's website, for the Mammy Global Network to find out the latest news. And in joining the Mammy Global Network, you'll also receive regular monthly updates on progress made, research planned, webinars planned to share experiences and information and so on. And that will give you a real insight into the work of the Mammy Global Network in scaling up their support for the most vulnerable infants and their mothers. So some examples have been given through this presentation. There's some research that has been completed, for example, in Bangladesh, in Ethiopia and other contexts, and also research underway or planned in Ethiopia, India, and also South Sudan. Of course, we presented a case study from Rwanda. So there's lots of experiences to draw from. And there is also a strategy that's being implemented by the Mammy Global Network in order to facilitate further scale up of this important approach. So I encourage you to visit the Mammy Global Network webpage at the link provided in the chat and also on this slide, thank you, Jodine, to find out more information.
Oh, that's perfect. Thank you. I think this seems like a really good time to wrap up the live Q&A, but just a reminder, we've been collecting your questions. There are some answers that are also down in the chat, and we will be making sure that a full list of questions and answers is available on the website, where the link is here, and it has been also provided in the chat. So I just want to take a moment to thank our long-standing donors and partners who support the MAMI Global Network and the IFE Core Group, and who have funded the development of the report discussed today. The USAID Bureau for Humanitarian Assistance, Irish Aid, and the Eleanor Crook Foundation. I'm just going to go on to the next slide briefly to let you know that we do have quite a few resources and references available at the link that has been shared in the chat. There are some orientation videos for MAMI for the Care Pathway package that give you an overview on YouTube. And there's, as Nikki mentioned, there is information about Save the Children's MAMI experiences in Bangladesh and in Ethiopia, and you can join the MAMI Global Network. And you can also please visit the IFE Core Group website for more information about the report that we've just released or about anything else related to infant and young child feeding in emergencies and our global operations guidance. There are a couple of references for some of the information that was presented here, and that will also be available on our website. So this closes out the end of this webinar, and I want to thank once again to the Global Breastfeeding Collective for hosting us for 2 more ways that you can step up. And I will say good evening now. Well, actually, good morning, good evening. Farewell.